Okay, everyone, welcome back to your second lecture. Hopefully, if you're listening to this first, please go back and listen to our intro PowerPoint that we did previously. So hopefully you have a good understanding of all of that material that we just covered. And now we're going to start to move into some specifics. And we're going to be talking a lot about ultrasound terminology and then moving into image orientation. Before we do that, I want to do a brief little anatomy recap here of some terms. So anatomic position, this is really for anything in healthcare. Any reference to a patient, we're going to be using the basis of this anatomic position. And the four criteria for this are going to be when our patient is standing. So we reference standing as either upright or erect. Our feet are going to be together. Our arms are going to be down by our sides, and our palms are going to be facing forward. So when we're referencing our anatomic position, we have to, in order to help us reference other sort of positional terminology. As we move through this here, our positional terminology, this may be a little bit of a recap, or you may be starting to get into this with your medical terminology course this semester, but we do need to know what these positional terms mean in terms of how our patient is positioned. So when our patient is supine, this means that they are going to be lying flat on their back, so their belly is going to be facing upward. When our patient is prone, this means that they are flipped over onto their stomach, so their back is upward. When they're decubitus, this is meaning that our patient is laying in an angled position, typically a 45-degree angled position. Sometimes it can be all the way up to a 90-degree position. We reference, or we rather further describe a decubitus by either right lateral or left lateral. So if we are in an RLD, that means our right lateral side is down on the table and our left side is upward. So we would be laying down on our right side with our left hip up in the air. If we are in an LLD, that's going to be the opposite. So that's going to mean that our left side is down and our right hip is up in the air. Now, when we're erect, like we said, this means that we are standing. When we are Trendelenburg, this means that our patient is supine, so they're laying flat on their back with their belly up, and the lower half of their body is actually going to be angled 15 to 30 degrees above their head. So they're going to be kind of inverted a little bit. Their head is going to be lower than their feet. And then the opposite of that, reverse Trendelenburg, this is when our patient's head is going to be up higher than their feet by 15 to 30 degrees. I was supposed to say degrees, not agrees on that slide. So here we have some nice diagrams showing all of these different positions. We can see the supine position, patient laying flat on their back with their belly up. Prone position, patient is belly down on the table. Left lateral recumbent and right lateral recumbent. Recumbent is kind of like an old school term for decubitus, so we usually just use either right lateral decube, left lateral decubed, or you may see the abbreviation of LLD, RLD. So make sure you know what that means. Right lateral decube is talking about the patient's right side down. Left lateral decube is talking about patient's left side down. And then we also have our Trendelenburg, where the patient's feet are above their head or higher than the level of their head, and reverse Trendelenburg, where their feet are lower. So in these positions, we're looking for gravity to help us with whatever exam we're trying to perform. So we see these quite a bit in radiography, but we also use these positions as well when we're doing a lot of vascular exams. And most of our exams, or our general exams, are just going to be performed in either a supine position or a decube position. We don't really scan anything in prone. It's just not something that is beneficial for us when we are performing exams. So now directional terminology, this is something that is going to reference that anatomic position. So again, we have to be aware that standing, feet together, arms by the side, palms facing forward. So we have anterior, posterior, superior, and inferior. These are kind of our basic directional terms. These are all talking about the relationship of two things to each other. So if something is anterior to a structure, that's going to mean it's in front of that structure. So if you have A in front of B, A is going to be anterior to B, but B is going to be posterior to A. So posterior means towards the back or behind a structure. We also can kind of see some old school terms with anterior and posterior, and that's going to be ventral and dorsal. If you have to remember the two of these, think dorsal fin. A dolphin has a dorsal fin on their back side or on their posterior side. So that's one way to kind of remember those directional terms. Now, superior and inferior, same thing. We're talking about the relationship of one structure to another. So if something is located above another structure, it's going to be superior. And if something is located below, it's going to be inferior. Superior can also be referred to as cranial or cephalic or cephalad. That's a really old school term, but you may still hear people refer to it as that. And inferior is going to be caudal. So again, to help you remember, superior, also known as cranial. Cranial means your head. So your head is your highest point on your body. That's the superior most location. So superior and cranial, a little way to remember those. Taking it a step further, we also have medial and lateral, and ipsilateral and contralateral. So still referencing two structures to each other here. Medial is going to mean it's located closer to the midline of the body than another structure is. Now the midline of the body, think if you were to draw a line all the way down from your forehead, coming down your nose, down your chin, down right through your sternum, right over your belly button, and down splitting in your pelvis. That's going to be your midline. So anything that's located closest towards that central line of the body is going to be considered more medial. Now lateral is going to be the opposite of that. So that's going to be located closer towards the sides. We can have a right lateral or a left lateral, right? Because are we closer to our right side or closer to our left side? Either further away from our midline on the right side or further away from our midline on the left side. Those are going to be lateral. Now, ipsilateral and contralateral are talking about sides. So if something is affecting the same side, it's going to be ipsilateral. If something is affecting the opposite side, it's going to be contralateral. So sometimes we can see a lot of patients' symptoms of, say, numbness, right? They may come in and they may have right hand and right foot numbness. That is going to be an ipsilateral symptom. Now, if they come in and they have right hand and left foot numbness, those are going to be contralateral symptoms. Finishing up with our directional terminology here, we have proximal and distal and superficial and deep. Proximal is going to be the closest point or closest to the point of origin or attachment, and distal is going to be the furthest away. So let's think about our heart for a second. Our heart is responsible for sending out blood to the rest of our body, and it does so by arteries. So our heart, let's say that that's the point of origin. As we send out blood further away to our arteries and our toes are going to be the distal most point away from our origin, right? Because the toes are the furthest away from our heart. Whereas maybe our aorta in our abdomen is more proximal than the arteries in our toes, right? Because it's closer to that heart, closer to the point of origin. So with proximal and distal, you have to be aware of what is the point of origin that it's talking about, right? What is our reference point here with this organ or this structure? And where am I looking in reference to that? Am I closer to that point of origin or am I further away to that point of origin? Superficial and deep. Superficial is going to mean closer towards the surface, and deep is going to mean deeper into the body or away from the surface. Here we have just a nice little diagram kind of showing all of those different terms. Again, you can kind of see here with that proximal and distal, looking at the patient's leg. If we're using our heart as a reference point I'm not sure if you guys can see my little arrow here. I hope you can. If you can't, somebody just send me an email and I'll make sure I adjust it for the next PowerPoints. But if we're using our heart as a reference point still on this picture on the right-hand side, the proximal part, the purple part of that arrow is going to be closer to our heart than the pink part or the distal part of that arrow is down at the toes. Now, medial and lateral as well. If we are to move that patient's left arm away from the body, we're moving it more laterally. And if we were to bring it down by his side, we would be moving it more medially. And then also on the left-hand side, we have cranial, which is superior. And then we have caudal, which is inferior. We have anterior, which is ventral towards the front of his body, and posterior or dorsal towards the back. So we have some anatomic scan planes that we use on a routine basis with ultrasound. So transverse and sagittal, this is our meat and potatoes, our bread and butter. We're using these two scan planes to look at everything. And then depending on what structure we're looking at or what approach we're using, we can also implement a coronal plane. But sagittal and transverse, that's going to be every single thing that we do. We look in both of these planes. Transverse is also known as axial, and it's if we were to imagine a horizontal line going right through the body and taking slices in that fashion. It's going to divide our body into superior and inferior segments. So it's going to be perpendicular to our midline and also perpendicular to the long axis of a vessel or an organ. Now, the long axis of a vessel or an organ is going to be sagittal. So sagittal and transverse are perpendicular to each other. So sagittal is going to show something elongated. It's known as longitudinal. It's going to travel vertically through our body. It helps us to divide the body into right and left segments. It's going to run parallel to that midline like we just talked about. And like we said, also going to be perpendicular to transverse, so it means it's parallel to the long axis of a vessel or an organ. Now, coronal, this is going to divide our body into anterior and posterior segments. It's in a similar fashion to sagittal, going to travel vertically through the body, but instead of moving the body into right and left segments, it's going to move in anterior and posterior segments. It's also going to refer to an image taken from the patient's side, regardless of the patient position. So whether our patient is supine or if they are in a decubitus position, if we are taking an image from the patient's side, we are always going to reference that as coronal because we're looking at the body in an anterior to posterior sweep. So here we can kind of see what those slices look like. Our transverse plane, like we said, is going perpendicular to that body. It's cutting that body into superior and inferior portions. And as we were to kind of slide that transverse plane upward or downward, we would be able to see the different levels of the body. Now our sagittal plane, this green or this blue slice going right down the middle. Remember we said our midline is if we were to draw a line from our forehead, down our nose, down our chin, down our sternum, down our belly button. That's going to be our sagittal plane, and it's going to move side to side. It's going to take slices side to side. Coronal is going to also be vertical, and it's going to move from our side. We said this is when we're taking images from the patient's flanks or the patient's side, so we're able to either move that forward or backward. We can move it anterior or posterior. So here is what some CT images would look like in all of these scan planes. So hopefully this can maybe piece some anatomy together a little bit more easily for you. So the image on the left-hand side, this is a coronal image. So we're coming in from the side, or we're taking slices from the side, and we're able to see, oops, sorry, my microphone just went out for a second. We're able to see all of the anatomy in that plane forward to backward. So as we were to sweep through the CT scan, we would be able to sweep all the way back through that spine and then all the way forward through the rest of that soft tissue. This picture in the middle, this is our transverse slice. So we would be able to sweep all the way up and all the way down. And then this picture on the right-hand side, this is a sagittal. So we're able to kind of see things from right to left. So we would be scrolling in from the patient's left side all the way to the patient's right side. So talking a little bit more specifically about image orientation with ultrasound, one of the biggest things that you have to do initially when you're starting to scan to make sure your image orientation is correct is you have to be aware of your indication notch or your indicator notch. This is a little notch, I mean, for lack of a better word, on the transducer itself. So on the camera itself, there's going to be a little indication where it says, this is your reference point. Where you put this notch is going to determine what your image orientation is while you're scanning. This is going to be your northern star. So if you ever get lost and you're like, oh no, did I flip my probe? Am I holding my probe the wrong way? Look at your notch and see what it's doing. The notch is always going to be pointed either towards the patient's head or towards the patient's right side. You have to take into consideration that we scan most of our exams with the patient supine, so the patient's right side is going to be towards us, so that means the notch is usually pointed towards us. But if our patient is being scanned in prone for whatever reason, now their right side is on the opposite side. So now the notch is going to be away from us. It's always in reference to the patient. So it's either towards the patient's head when we're scanning in sagittal or coronal, or it's towards the patient's right when we're scanning in transverse. So let's take a look at what our transducer with that notch is going to look like. So there are a bunch of different types of notches, depending on the manufacturer, depending on the type of equipment that you're using, the notches can look different, but there's always going to be some indication on one side of the notch that says, hey, I'm your little indicator. So on this big picture, I hope this little thing works. Let me know if that doesn't show up because I'm going to use the pencil just to make sure that it does. So this right here, and then it also gives us a secondary one right here to say, hey, this side of the probe, this side of the transducer should always be pointing upward in sagittal or coronal and should always be pointing to the patient's right and transverse. This one is going to be right here. So you can see how they look a little bit different from each other. Okay, so let's talk about our scan approaches. Now we're going to kind of add everything together here. So we're going to take it plane by plane. We're going to start with sagittal. Like we said, we're holding our transducer notch with that notch pointing up towards the patient's head. When we're doing that, we're able to sweep right to left, medial to lateral in the patient to get information from those areas. So our images are going to be obtained with either anterior or a posterior surface scanning approach, typically from the anterior aspect. We scan 99% of our patients in supine, so we're going to be coming in from their anterior side. We're putting the probe or the transducer down on their belly. Their belly is anterior, okay? Now, our image orientation is going to give us information about structures in the body that are either anterior, posterior, superior, or inferior. And here is my little diagram, so bear with me. We have our notch right here, right, pointing towards the patient's head. Directly, when we're looking at our screen, we're now looking at our image. Directly underneath the surface of our transducer is going to be our anterior tissue here. So that is saying, hey, at the top of your picture, I'm all of the anterior structures. I'm all of the anterior tissue. As that sound wave travels down into the patient's body, we're getting all of this posterior and deeper information. Posterior anatomy towards the bottom of our picture. Think of your transducer as a flashlight, right? You're going to have the strongest beam first right underneath that body, so you're going to be able to see all of that anterior tissue, and then that light is going to kind of shine outward. It's going to fan outward, and you're going to be able to see further away, more posterior, more into the body. Now on the right and the left side of the screen, the left side of the screen is going to indicate tissues closer to the patient's head. So this is going to be our superior anatomy over here. If we were to slide our transducer up the patient's body, we're going to see more, we're going to see our actual picture move this way. If we were to slide our transducer down towards the patient's feet, we would move more inferiorly on our screen down this way. Okay. Now we have, this is kind of just a brief little recap of that as well. So here we're holding our transducer in sagittal, our notch is pointing up towards the patient's head. We're going to be getting anterior anatomy towards the top of our screen, posterior anatomy towards the bottom of our screen, superior anatomy or closer towards the patient's head on the left side of the screen, and inferior anatomy closer towards the patient's feet on the right side of the screen. Next, we have our transverse. So now we said when we're in transverse, our notch is going to be pointing towards the patient's right. So our patient is still being scanned from an anterior approach. They're in a supine position, so we're putting that probe on their belly. Their belly is the anterior surface approach. So the patient's notch, or the notch, is going to be towards the patient's right, which is going to be pointing towards us in this scenario. Similar to sagittal, right? We're still thinking of this transducer as a flashlight. We're still getting anterior anatomy at the top of our imaging screen. As that flashlight travels into the body, we're going to get posterior information. So up here, we're going to have the patient's skin, right? We're going to be able to see what's going on with the patient's skin. And down at the bottom of our picture, we're going to see the patient's spine. And that's going to be the same for sag, transverse, and coronal, okay? The further down our picture we go, the deeper into the body we go, the more posterior we go. Now the difference between sagittal and transverse is that the right and left side of our screen is not going to indicate superior and inferior anymore, because in transverse, we're really not moving up the patient's body or down the patient's body. Now we're moving side to side. And we can sweep up and down, but that's not going to change what's happening with our picture. If we wanted to see something more on the right side, say we wanted to go and look at that right-sided kidney, we would slide our camera over this way and our screen would move this way. If we wanted to move to the patient's left side or see that left kidney, we would sweep our camera that way or slide our camera that way, and our screen would move this way. So our screen is a direct reflection of what we're doing. It seems a little bit backwards that the right side of our screen is showing us left-sided anatomy, and the left side of our screen is showing us right-sided anatomy. But in medical imaging, everything is in reference to the patient, not how we're looking at it. So we're looking at the patient, right, front to back, or rather front to front. Their right side to us is on the left side. Does that make sense? So remember, everything is going to seem like it's flipped, but it's not. It's always in reference to the patient. And that goes for X-ray, that goes for CT, that goes for MRI, that goes for everything. Everything is in reference to the patient's anatomy. So again, kind of just a positional relationship here. We're holding that notch towards the patient's right side with an anterior approach. We have anterior anatomy at the top of our screen, posterior anatomy at the bottom of our screen, right-sided anatomy on the left side of our screen, and left-sided anatomy on the right side of our screen. A lot of machines will have this little blip right here, this little dot, this little something. That's going to tell you that, hey, your notch is on the right side of your probe. If you ever see that on this side, your image is reversed. So there is a visual representation of the indicator notch on the screen as well. So it's not just a physical notch on the probe. You can also make sure that your image isn't reversed on the screen itself. And lastly, we have our coronal plane. So we said we're not performing this routinely. This is something that we're using as a supplementation type of scanning approach, or depending on what organ we're looking at, will come in a coronal plane. So this is going to be when we obtain pictures from either the right flank or the left flank. Flanks mean your sides, the sides of your abdomen. So we're coming in from either the right or the left side, and we're still going to have similar anatomy to sagittal, where our notch is still pointing up towards the patient's head, but instead of getting anterior and posterior information, we're now technically going to be getting lateral and medial information. So we're not really able to appreciate if something is in front of or behind another structure, but we're able to use that flashlight to say, hey, if I'm coming in from the side, as my flashlight travels deeper into the patient's body, I'm eventually going to hit their spine. And from this plane, that's considered medial. This is the medial most part. And then the skin from this plane is going to be the lateral most part. So I don't technically want to say that, but this is going to be our approach for coronal. So sagittal and transverse, because we're using an anterior approach, an anterior anatomy and posterior anatomy are going to be at the top and bottom of the screen, but because we're not really using an anterior approach with a coronal scan plane, it changes that top of the image anatomy and bottom of the image anatomy. Okay, moving into some anatomy recap again, we do have some abdominal regions that we have to kind of briefly talk about. We can divide the body either into, or rather the abdominal cavity into either 9 regions or 4 quadrants. Our 9 regions are going to be our right and left hypochondrium with the epigastrium right in the middle. We have a right and left lumbar region with an umbilical region in the middle. And then we have a right and left iliac region with the hypogastrium in the middle. Our quadrants are going to be right upper, right lower, and left lower quadrant. And here we can kind of see what those regions and quadrants look like. When we're using quadrants, it's a little bit more of a broad evaluation because we're including more anatomy and more structures in each quadrant, whereas the 9 region method is a little bit more specific. And we also have some abdominal wall surface landmarks that we have to be aware of. We kind of talked about the midline briefly in the PowerPoint, but there are some additional ones that we need to know about. We use the midclavicular line pretty frequently. So this is where if we were to draw a sagittal line right down the mid portion of each clavicle, that would be our midclavicular. That's going to be our red line on our diagram. We also use our mid-axillary plane quite a bit as well. This is technically going to be a coronal sort of approach. This is going to be our blue line where we take our axilla, which is the medical term for our armpit, and if we were to draw a line all the way from our armpit down to our feet from that side view. We also have to know where our xiphoid process is. That's going to be our orange dot on there. That's actually where we use CPR in terms of a reference point for CPR. We're going to be palpating and feeling for that xiphoid process to know that we are doing CPR at the correct level. We also have our iliac crest, so that's going to be where our hip bones or our hip wings are at the highest point. They're also something that we are able to palpate, so we can actually feel that iliac crest on most of our patients. That's going to be the indicator of, are we doing an abdominal exam or are we doing a pelvic exam? Anything below that line, we're going to be doing a pelvic exam. Anything above that line, we're probably going to be doing an abdominal exam. We also have a subcostal plane. This is going to be the level of the 3rd lumbar vertebrae. So anatomy recap, we should know we have a cervical spine, a thoracic spine, a lumbar spine, a sacrum, and a coccyx. So at the level of our 3rd lumbar vertebrae, that's going to be our lower back. That is actually going to be our light green or our lime green line. We also have our transpyloric plane, which is going to be at the level of the 1st lumbar vertebrae, so a little bit higher than the subcostal plane. Transpyloric is talking about the level of the pylorus segment of the stomach. So yes, it's going to be the level of the 3rd lumbar vertebrae, or sorry, the 1st lumbar vertebrae, but it's also referencing the level of where the pylorus typically sits in a patient's stomach. We have a transtubercular plane. This is going to be at the level of the iliac crest. So we're using that landmark of the iliac crest to say, hey, here is the tubercle part of a patient. And that is pretty much it for our abdominal landmarks that we can use to reference. We also have some abdominal contents that I need you guys to know where they are for this course. We get into more specifics as we move forward, but just prior to really getting started in lab, I want you guys to understand where these organs are typically located in the average patient. Our liver is located in the right hypochondrium with a small portion of it extending into that mid-epigastric region. We also have our gallbladder, which is situated in our liver, so it's still going to be in that right hypochondrium. Our pancreas sits upper and midline, so our epigastric region. Our spleen is on the left hypochondrium side. Our stomach is at that transpyloric plane. Our kidneys, our right kidney is going to be located a little bit lower than our left kidney, and that's because our right liver, or the liver on the right side, is so large that it pushes the right kidney down. The left kidney doesn't have to fight with that big of an organ on the left side, so it's going to be a little bit higher. So the right kidney is going to be slightly lower than the left kidney, at the level of the transpyloric plane typically for both of them, but the right one's a little bit lower. Our great vessels, which are known as our aorta and our IVC, are going to run parallel right down the midline. Our aorta is going to be on the left side of the IVC, and the IVC is going to be on the right side of the aorta. Our small intestine, the central portion of this, is going to be occupied by that small intestine. Our large intestine travels around it, so the periphery of that small intestine. Our appendix is located in the right iliac region, and our bladder and prostate for male patients is located in the hypogastric region. So that is it for our basic terminology and image orientation portion of this. I really want you guys to focus on that image orientation. I want you to have a good abstract understanding of what that looks like. It will make more sense when we see it in lab and you're able to look at how our image adapts while we're scanning. So please make sure you have a good understanding of specifically the scanning planes and the scanning approach. We're going to spend a lot of time on that in lab, but that tends to be some of the hardest concepts to understand at this point. Any questions, please email me.